One of the questions that we are faced with, especially in families that have a history of breast cancer, is the question, would taking tamoxifen, the anti-estrogen pill, for 5 years be beneficial? This is actually a rather complex question that depends on many factors. My sense of a drug for prevention is that it should be incredibly easy, should be very non-toxic, shouldn't interfere with your life, shouldn't make you worry about long-term toxicity, and be cheap. Tamoxifen for prevention fits some of those, but unfortunately not all. There are several major studies that have been done over the past 10 or 15 years in trying to answer the question, how important or how beneficial is tamoxifen in preventing breast cancer? The P1 trial, which is a large trial done in this country, had the best data and in fact showed that the relative risk of recurrence in patients that took 5 years of tamoxifen was about 50%. While that sounds very good, that's the relative risk of recurrence, not the absolute risk of recurrence. The absolute numbers per 100 people are dependent on that patient's risk of breast cancer in the first place. The other issue that always comes up, especially with tamoxifen in the prevention setting, is the toxicity of tamoxifen. While one can argue that the toxicity of tamoxifen in patients who we're treating with established breast cancer is reasonable, one worries more when you're using it in the preventive setting in women, obviously, that don't have a history of breast cancer. Those two toxicities are cancers of the uterus and deep vein thrombosis and possible pulmonary embolus. Both of those toxicities are increased with age, and while quite rare, can occasionally be life-threatening. The ideal person to treat with tamoxifen would be a higher risk person such that the potential benefit is better. That ideal person would be a young person with a strong family history of breast cancer who doesn't have a uterus. Unfortunately, that's not the most common situation. The toxicity as one gets older with an intact uterus, pretty soon the toxicity may equal or exceed the benefit. The other issue is that there are a number of short-term side effects of tamoxifen, such as hot flashes, night sweats, vaginal dryness, sexual dysfunction, that really are more than one should put up with for a drug for prevention. When I have a situation like this, the patient and I evaluate the numerical potential benefit, the potential risks, and make a decision at that point whether to do it or not. However, I think most importantly, if we decide to try 5 years of tamoxifen for prevention, I will have the patient start on the tamoxifen and then see them a couple months later to see how they're doing with it. If they're having much trouble at all, night sweats, hot flashes, sex problems, it's just not worth it. On the other hand, if they come in and say it doesn't bother them at all, then for many situations, one is reasonable to accrue that benefit with potentially minimal risk. It's often a difficult discussion. There are now tables looking at various age groups, risk patterns, intact uterus or not, that actually will give a much better numerical answer to the question as to whether the benefits outweigh the risks, and those should probably be looked at. In sum, I think that while there's a lot of enthusiasm for tamoxifen prevention, on a practical sense, the majority of patients who head down that road probably, in fact, do not finish 5 years of tamoxifen. And for many of those patients, the benefit-risk ratio is not high enough to warrant giving the tamoxifen in the first place.
Hi, I'm Dr. Jay Harness, and I want to share with you important information that I believe that every newly diagnosed patient with breast cancer needs to know.
I'm a breast cancer survivor.
I am a breast cancer survivor.
I am a breast cancer survivor.
And I want every woman to know
about personalized breast cancer treatment
and the genomic test.
A test that helps guide a woman and her doctor
to the best treatment options for her.
Pass it on.